Corneal transplantation is a procedure that involves either removing the cornea in its entirety or selectively removing layers of tissue to replace those that are damaged, either from infection, scarring, or when the cornea has become misshapen, for example, in keratoconus, or also when the pump that helps keep the cornea clear becomes damaged, either through age or following cataract surgery, or through inherited conditions such as Fuchs' endothelial corneal dystrophy. Many different people may qualify for corneal transplantation. It is typically when normal medical intervention cannot help the patient any further, or indeed when spectacles or contact lenses can't improve on somebody's vision, and the last resort is to undertake a corneal transplant to help visually rehabilitate them. Occasionally, corneal transplantation is employed to help save the eye, for example, in a severe infection or following a severe trauma, where we're unable to maintain the integrity of the eye, and the only choice is to actually replace selectively or all of the cornea in that circumstance. There are broadly three categories of corneal transplantation. The first is called penetrating keratoplasty, or full thickness corneal transplant. This was the first procedure to gain traction over 100 years ago now, and is usually left in reserve for cases which are more complicated, involving the full thickness of the cornea, or when other selected types of procedure are not possible. In the last 15 years, huge advances have taken place in selectively removing parts of the cornea. In other words, trying to maintain and take advantage of the integrity of the eye itself. So, for example, a very large procedure would be a deep anterior lamellar keratoplasty, used for conditions such as keratoconus or scarring of the front of the cornea. This involves removing most of the front part of the cornea and leaving the back surface intact, and then transplanting somebody's tissue who's died and donated it. By contrast, endothelial corneal transplantation involves selectively removing the cells lining the back of the cornea that have become dysfunctional, such as in Fuchs' endothelial dystrophy. And there are two main types. One is called the DSEK, or Descemet's stripping automated endothelial keratoplasty, or DMEK, Descemet's membrane endothelial keratoplasty. Both types are a keyhole procedure that will involve putting a new layer of cells from somebody who's died and donated it into the existing cornea in order to regenerate it. There are pros and cons with both approaches, but both can help visually rehabilitate patients. Recovery from corneal transplantation is variable and depends on how complex the surgery is in the first instance. It also depends, of course, if somebody has, for example, coexisting cataract surgery that we may not address at the time of surgery. So typically, a deep anterior lamellar keratoplasty or penetrating keratoplasty involves multiple sutures in the cornea, which would need to remain intact for between 6 and 18 months before they would be removed. An endothelial transplant is a much faster procedure in terms of recovery, with a DSEK expected to sort of regain their vision within a month, and in DMEK, that may be as quick as 1 to 2 weeks. There are less sutures as well, and so they can be removed at a much earlier juncture, usually at around 1 to 3 months. Success from corneal transplantation is typically quite high, in excess of 90% to 2 years for most of the major types of surgeries. For the penetrating keratoplasty, the risks of rejection, i.e. the body recognizing the tissue as being foreign and treating it as if it was a cancer or an infection, is higher than for selective tissue replacements such as DOLC, DSEK, or DMEK. And that's in fact one of the reasons that we've gone for selective tissue replacement now, because it's less likely to cause a rejection episode. Typically, patients would receive anti-rejection drops in the form of steroid drops and wouldn't require anti-rejection tablets as they would for solid organ transplants, such as a kidney or a liver. Additionally, the tissue doesn't need to be HLA or donor matched in the way that other types of transplants would occur. Rejection episode, if it's recognized earlier, usually in the form of reduced vision, blurring, or redness of the eye, or discomfort, can be reversed with an intense course of topical steroid drops again. If the graft sadly were to fail, then you can redo a corneal transplant, and it is easier to replace those that have already gone selective tissue replacement because you're not having to replace the entire cornea. And of course, the risk of getting a rejection is much lower in that circumstance as well. There are, of course, a much longer list of complications and risks that we would discuss with patients depending on their circumstances and what kind of intervention that they might require. The biggest obstacle that we have internationally to undertaking corneal transplantation currently is a lack of donor tissue availability.